If you look at studies focusing on outpatient surgical procedures, the one that is associated by far with the most complications, reoperations, readmissions, etc., is the TURBT, or the transurethral resection. And so there's, as with anything in medicine, there's no small procedure, but a transurethral resection really clearly has its morbidity. And think about the risk we take in terms of stopping patients on their anticoagulation, which we have to do. We're actually doing a procedure that, as you said, is diagnostic and therapeutic, but definitely has its risks.
Hello and welcome to our Winnovations podcast. I'm your host, Dr. Kyle A. Richards, and we have a very exciting program planned for today. We're currently in our third season and thrilled to be back in the studio in the Department of Urology at the University of Wisconsin. Just to remind folks, the purpose of these podcasts is to highlight some of the exciting and innovative work being done at the University of Wisconsin. But for this season, we're also bringing in some really great guests from outside our department to provide unique perspectives and highlight the collaborative efforts that are required to innovate. We also want to generate discussion in the broader urology community so that we can continue to work together to make innovative advancements in urologic care. So with no further ado, I'd like to introduce my guests for today. We have Dr. Elizabeth Betsy Coney and Dr. Sam Chang. Dr. Chang is a professor in the Department of Urology at Vanderbilt University, where he serves as Chief Surgical Officer at the Cancer Center and Chief of Urologic Oncology. He did his medical school and residency at Vanderbilt, followed by his fellowship at Memorial Sloan Kettering Cancer Center, and recently was awarded the prestigious Hugh Hampton Young Award via the American Urologic Association. Sam, it is so good to have you on the program today.
Kyle, it is my honor and privilege to share some time with both you and, actually more importantly, with Betsy.
You are a gentleman and a scholar, indeed. And Dr. Betsy Coney is an assistant professor of urology at the University of Wisconsin, where she joined faculty in 2024 after completing her fellowship in urologic oncology at the University of Washington. Prior to that, she was a urology resident just down the road in Chicago at Loyola University. And since joining our practice, she's been just a wonderful addition. I've really enjoyed getting to know her and her family. Has brought new techniques to our system, including transperineal prostate biopsy, as well as retroperitoneoscopic renal surgery. And I know is extremely passionate about bladder cancer as well. And welcome to the program, Betsy.
Thank you. Thank you for having me. Yeah, it's great to be here with both of you, and I'm looking forward to this discussion.
Excellent. And we are going to discuss our topic for today, which is advancements in bladder cancer. The future is now. And there's been a lot of advances in bladder cancer over the past 5 years. We're going to focus mostly on non-muscle invasive bladder cancer. We could do a whole separate session on invasive or advanced bladder cancer.
Thanks for the future invite,
right,
Kyle. Happy to do it anytime.
Right. We'll schedule that for season 4. We'll have a reunion of Sam and Betsy because I think we'll definitely need to get the band back together. And for me, after hosting this podcast for the past 3 years, this is the one I've actually been most excited for. It's something that I actually know something about, so this is really exciting for me. And it's actually the first episode we've done on bladder cancer in the past 3 years. So this is big time. Now, Sam, I want to start with you. You're very interested in bladder cancer, as I know. How did you get interested in caring for patients with bladder cancer? I know you wear a lot of different hats in your department, but how did you come to have a passion for taking care of patients with bladder cancer?
The opportunity actually started with patients, Kyle. The volume of patients in the Southeast in Nashville where I practice who unfortunately have exposure to some of the most well-known smoking factors, which is actually that's the key to the risks associated with bladder cancer is smoking. I often tell patients it's cigarettes are the number one risk factor, followed by smoking, followed by tobacco. And they usually capture all three of the smoking, cigarettes and tobacco. So that practice here built quickly just because of the sheer volume. And I was fortunate enough to get associated with the AUA guidelines back in 1999. And from that point on have been associated with guidelines ever since. That was led by Dr. Smith. And then I actually became part of the guidelines as they became updated and changed over time.
And for you, Betsy, what was it about taking care of patients with bladder cancer that drew you to the field?
Yes, my dedication to taking care of people with bladder cancer really comes from the patients first and foremost. And early in my medical school career, when I was first exposed to urology, it was seeing urologists taking care of people with bladder cancer that was one of the experiences that stood out to me, and about how this can be such a complex and really difficult disease to take care of, and the way that urologists can be there with patients from very beginning, right at the time of diagnosis, through the cystectomy or maybe a nice long follow-up of surveillance with good news on cystoscopies. And so that always really appealed to me, and continues to keep me very, very dedicated and thankful to take care of these patients.
Yeah, I've been doing this for 11 years now at University of Wisconsin, and it's amazing, still seeing some patients from 10 or 11 years ago with bladder cancer, and, they come in, they ask about my family, and we talk about their families, and yeah, it's been very rewarding for me as well from that sort of longitudinal patient relationship perspective. I wanted to talk to you guys about transurethral resection of bladder tumor, which is TURBT for some of our listeners out there that are non-medical, is a common procedure that we do to diagnose and treat early stage bladder cancers. And the procedure's been around for a long time, and it's kind of an unusual way of handling a cancer, because you cut it up into small pieces and then extract it from the bladder. But it seems to work reasonably well. Have there been, Betsy, I'll throw this one to you maybe to start off. Have there been any advances in TURBT or surgical management, things that you're maybe excited about in the past decade or looking forward in the future?
Yeah, there are a few things that have really enhanced our toolbox within the TURBT. I think overall TURBT, it is both a good procedure for its diagnostic sense in some ways, and it can be therapeutic. It also still has certainly some shortcomings, in that maybe sometimes we're spreading more cancer when breaking up the tumors in the piecemeal fashion, or so it's both a good technique, and it still has some room to improve. But within the TURBT, I think the kind of the way that we have more tools, and it's more of like a nice Swiss Army knife instead of just a one kind of basic pocket knife, has evolved. And so some things that I do in my practice are, I like to do some on block TURBTs, really just for small tumors, and the tumors that are a good location for it are if they're kind of on the lateral wall or posterior wall, and maybe they have a small stalk but a bigger, more expansive papillary component, but still it can't be that big. But those are nice to just chip away at the bottom and get it out in one piece. There's some evidence that doing on block TURBTs for small tumors may reduce the recurrence risk, or at least in the relatively early period, by about 1 year after the initial procedure. This is still limited by, we have to be able to get the tumor out, so it's not really suitable for big sessile tumors, but it's just another good technique to have in the toolbox. And then the other one that I do like is blue light as a form of the enhanced view cystoscopy, and that can be helpful for both identifying CIS, or sometimes in people who have lots of very tiny papillary tumors and you want to try to get all of them. That's a nice way to highlight those.
Yeah, those are all good points, Betsy. What about you, Sam? Anything in the TURBT or the tumor resection arena that gets you excited or has evolved as your career has progressed?
I think those two that Betsy outlined, the combination of enhanced cystoscopy. These are techniques to better visualize tumors, as well as the actual technique. I mean, the point that you raised, that we've been doing this for a long time. It's been for more than 100 years. And if you look at old instruments that we use, they look very, very similar to the instruments we use today. We're actually, one of my partners here at Vanderbilt, Carroll, I'll give him a plug, is actually helping develop actually a robotic technique with instruments that can actually have more range of motion within the bladder to help visualize, to help remove, and actually utilize some of the unblocked techniques. It's like anything we do, we have a simple stick that goes in with the cystoscope. If we can actually manipulate these with multiple instruments inside, we're only going to get better. So that's exciting. But hopefully we can continue to have technological improvements.
Yeah, I mean, I think I see patients not infrequently sent in that just have difficult to reach tumors that are, anterior, up at the dome, and the current sort of rigid instrumentation it's not designed and sometimes not feasible to get to those areas. So I'll be excited to see what Dr. Harrell comes out with. And I've been, I think bipolar, I think has been a nice advance. I remember in my early years of training, we were doing monopolar resections, and then bipolar came along, and I think now almost everyone's using bipolar, and I think that's safer, and I think that was a pretty nice win for our patients. But I guess the next follow-up question then, and I'll maybe start with Sam on this one, is do we underappreciate the morbidity of the TURBT from a patient perspective?
Unquestionably. Every single time we perform a TURBT, the burden on not only the patient, but his or her caregiver, the post-operative recovery, the possibility of complications associated with resection, including bleeding, infection, requiring another catheter, are actually quite real. And if you look at studies focusing on outpatient surgical procedures, the one that is associated by far with the most complications, reoperations, readmissions, et cetera, is the TURBT, or the transurethral resection. And so there's, as with anything in medicine, there's no small procedure, but a transurethral resection really clearly has its morbidity. And think about the risk we take in terms of stopping patients on their anticoagulation, which we have to do. We're actually doing a procedure that, as you said, is diagnostic and therapeutic, but definitely has its risks.
Yeah, it's one thing that I've thought about a lot, having been in practice now for a decade and doing a lot of these procedures, is we oftentimes maybe don't see that side of it either, because the patient is maybe calling and talking to the nurse or going to their local ERs, and we may never even hear that piece. But I saw a recent study that quoted a 10% rate of unplanned office or ER visits following TURBT, which I thought was impressively high, which brings me to my next point that I'll maybe toss over to Dr. Coney. So given this unquestionable morbidity of the procedure, do we have any alternatives at this point to transurethral resection? Anything coming down the pipeline, anything that you would consider?
Yeah, so something that recently got FDA approved that we are just now starting to offer at UW is UGN-102, or Zosduri. So this is the reverse thermal gel that has mitomycin in it, and starts out as a liquid, and then at body temperature turns into a gel, and then patients void it out over the next 4 to 6 hours. So this is something that is approved for new or recurrent intermediate risk non-muscle invasive bladder cancer. So people who have multifocal low-grade bladder tumors would be a good candidate. When they looked at this in the study, so the first was the Atlas study, that was the phase 3 prospective trial. And this was comparing the Zosduri to the TURBT, and so it really was designed as an alternative to surgery. And early on, they had pretty similar recurrence-free survival rates. So their first outcomes, they said both arms were about 65% disease-free at 3 months, and then for people who were disease-free initially, they did have some good long-term outcomes. So by about 15 months, they were 72% for the UGN 102 resistory group versus 50% in the TURBT alone. They're saying in the company, from their more recent trial, the Envision, which was a single-arm trial, that's what the company is saying on their website and pamphlets, and they're quoting about an 80% complete response at 3 months, and then 82% for people who are disease-free. 82% are disease-free at 12 months. So I think there is a role for this. My first patient that I have lined up for this is an older lady in her 80s who has a few small low-grade tumors, and the bladder cancer diagnosis is new for her. And so we're going to give it a try and see if we can avoid a TURBT. There's not that much to lose. If it doesn't work, then we'll just go on and do a TURBT. But I think particularly some of these elderly patients who have more comorbidities and are at higher risk of complications around anesthesia, maybe you don't want to have them stop their blood thinners. That's a great point that you made earlier about some of the perioperative risks. So I think that's probably a good patient to try it in.
And Sam, this is really kind of a paradigm shift in management of bladder tumors, right? I remember it being sort of sacrilegious to say you wouldn't do a TURBT prior to any sort of intravesical agent. So do you think this is a move in the right direction, or is it too early to say?
No, I think it's a very promising point that you just raised that Betsy emphasized regarding the fact that instead of doing a resection, actually doing a chemoablation. So actually having these patients that we know that have low-grade disease, just as Betsy described, multifocal, we are probably going to have a more effective treatment by treating the entire bladder as opposed to what we just visualize, and by avoiding a trip with general anesthesia and the resection. It's an option. I think it's along the treatment kind of pathway of surveillance. There are definitely some patients with low-grade small tumors that I do surveillance. This gives another non-operative management, and there are those that if we're more concerned or a new patient, for sure we're going to do a resection. So having another alternative gives the patient and their families another alternative, which I think can only be beneficial for the overall population.
Yeah, and I don't know if we didn't really talk about this, I don't think, but there's also office, full duration, sort of along the lines of surveillance, which I think in the right patient can be a good option and oftentimes well tolerated. Now, within this drug, as Betsy alluded to, Zosduri is approved in the low-grade, intermediate risk population. And Sam, you and I have talked about this before, that intermediate risk group from the AUA, SUO guidelines that you were part of is quite a heterogeneous group of patients. You've got some low-grade recurrent patients and then high-grade small tumors. They're lumped into that intermediate risk group. And oftentimes it can be a little bit of a conundrum with knowing what best to do from a treatment standpoint. So are you excited about any of these? There's quite a few clinical trials in this space. Is there an agent or a drug that you're kind of most excited with that's maybe coming down the pipe that can help in these patients?
It's a great question, Kyle, because it's a big bucket. Like you said, we've got a high-grade bucket that can be also a very high-grade bucket or a very high-risk bucket. And we've got a low-risk bucket, and we have this intermediate risk group that kudos to the groups that are continuing to try to refine the patients and sub-defining them. But whenever you have a table like this or a risk stratification system, you're going to have outliers and you're going to have some heterogeneity, just as you said. But if you look at many of the agents that have been used in more advanced disease or the BCG unresponsive disease, many of those agents, including agents such as the adstiladrin, which is the interferon type of intravesical therapy given once a quarter. If you're looking at also the CG oncology medication, which is cretostimogene, that's a medicine that actually stimulates also the immune system. That's also actually not only a combination of GM-CSF, but also looking at the ER pathway as well. You're looking at medications that could be used earlier that have a very good safety profile that should have hopefully few complications, but that could be very beneficial. Are we going to be using them for all these patients, intermediate risk? Again, I think we're looking to add to our list of possible therapies that will talk about pros and cons, cost and benefit risks associated with each of these, and pass that on to our patients.
Anything from your standpoint, Betsy, to add to that sort of intermediate risk group, things you're looking at coming down the pike?
Yeah, I completely agree that this is a very broad group, and certainly the goals are, as Sam was saying, to balance cost and burden of treatment with keeping people from having recurrences, hopefully, as that can be very distressing and may lead to more TURBTs, etc. I'll be interested to see how those more immunotherapy type treatments like the crudostimogene and nadofaragene adstiladrin, how they work in this population, because I don't think of low-grade bladder tumors as really being very immune activating. Or molecularly, they're pretty immune cold or kind of inert, although some of the mechanisms of these novel therapies do seem like they're trying to reverse that from the cellular level and release more immune signals. So maybe if those are effective, they could provide a longer disease-free benefit for patients. Another one that I think is interesting that I've only seen a little bit of data about is the TAR-210, the erdafitinib pretzel. And so this is using erdafitinib in the sustained release pretzel in the bladder. And erdafitinib is interesting from a mechanistic perspective because it does use the FGFR mutation or alteration that a lot of low-grade bladder tumors have. And so it does, from a biological perspective, have some promise in that maybe it is the right mechanism for this disease. But I've only seen a little bit of early data that I think they shared at a conference, but I'm looking forward to that over time too.
Yeah, that's a good point. I think that was the Moonrise trial, I believe, TAR-210. And then you both hit on the two other trials, the Pivot trial, which was for crudostigmogene, SUO-CTC sponsored, and then ABLE-32, which is adstiladrin. So those are just the names of the trials, and we'll see what the Pivot trial has accrued, so we'll get some data from that probably in the next 1 to 2 years. So exciting stuff. I wanted to switch gears maybe now to high-risk non-muscle invasive bladder cancer. So Betsy, is BCG still standard of care?
Yes, but it's great to be at a point where there is at least one other good option that people seem to use in the real world pretty freely. That would be gemdosi or gemcitabine and docetaxel. It'll still be a little bit before we get the bridge data out, but from the retrospective and just people's just daily life experience, that seems like a good alternative, which just makes the BCG shortages less stressful. But yeah, I still do use BCG as the first line for a new high-risk non-muscle invasive bladder tumor that I've just diagnosed.
Sam, is it wrong in your opinion to give gemdosi first line?
Is it wrong? Loaded question, Kyle. Way to throw that out there. Is there ever a right or wrong? Sometimes
I'm asking you the hard questions.
No, I think the points that Betsy raised were of course, on point regarding retrospective trials when there is a shortage or inconsistent supply. Then yes, we do use gemcitabine docetaxel as a first-line treatment. But when BCG is available, BCG is our first choice, and we'll look forward to the prospective data that the bridge trial led by Max Cates will really help kind of answer that question of whether or not it truly is equivalent, non-inferior, perhaps superior to BCG. That BCG distribution, the inconsistent supply, to me remains a black hole. Why certain locations will get it, why others won't, why large city centers in New York City, in Philadelphia, in Boston, in Atlanta, large cities, why they can't get BCG. It still baffles me, and it's unclear and Merck has done everything they can to try to increase the supply, and they're working on another building, et cetera. But it remains quite mysterious why the supply remains so inconsistent.
Yeah, and Merck has said that their new facility will be up and running in 2026, which will allegedly triple their current output of BCG. So we'll see, right? It'll be interesting. I know as long as I've been in practice, we've had a shortage intermittently, and we've tried to do a lot of different things to mitigate that locally. Is there anything, Sam, that you're doing at Vanderbilt to try to conserve the supply that you have, or are you following the SWOG protocol to a T?
No, that's a good question. Fortunately, we recently have not had a shortage, but we have shortened the maintenance. When we actually look ahead, our pharmacy and our nurse practitioners that lead our installation clinic, we have an idea of schedule of how many vials will be needed, what's coming up, and we review that at least every month, usually even weekly, regarding, hey, these are the numbers that we have, these are the patients, and if we have to make decisions, it usually is maintenance that is cut first. And we tend to give longer courses for T1 disease as opposed to TA. So different things come into play.
Thanks for tuning in to part 1 of Advancements in Bladder Cancer, The Future is Now, featuring Dr. Sam Chang and Dr. Betsy Coney. You're listening to Winnovations, and I'm your host and founder, Dr. Kyle Richards. I want to thank our producer and editor, Sandra Miller, as well as our department chair, Dr. Stephen Nakata. Lastly, I want to thank all of our listeners for tuning in.
Winnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.